Thank you very much for the kind invitation to talk about the EU-MuSK project. I'm Till Uhlich. I'm from the Department of Rheumatology at the Diakonhjemmet Hospital in Oslo. I'm a researcher and a clinician. That's what I wanted to show you. This is Liang Yong, a 30-year-old Chinese male. He weighs 220 kilos, so he's extremely obese, and this affects his musculoskeletal organs. And he's currently being helped out of his local hospital, a name which I don't recall, by a young doctor and his sad-looking father. It's easy to imagine that the prospects for life are poor for Liang. He will have difficulties moving around, and he will certainly not be able to date these girls. Oh, it's working. This is also a debilitating disease. It's generalized osteoarthritis. And as you can see, there are enlargement of the distal and interfungal joints in the fingers due to bony enlargement, which you can see on the X-ray of osteoarthritis, opposed to rheumatoid arthritis, where bone is going away, there are erosions. And from an operation, you can see the erosions working their way into the cartilage and into the bone. There has been a major collaborative effort by Tuluki Sokka initiating a quest with more than 8,000 patients being examined and assessed in a number of European countries and also outside Europe, such as in the USA and Canada and other countries. And this is a cross-sectional approach where one looked at disease activity in rheumatoid arthritis. And as you can see, disease activity is here, and the different countries are listed down here. And levels of low activity in RA were mainly found in affluent countries like the Netherlands, Finland, USA, while other countries like Latvia, Poland, Argentina, Lithuania, and Serbia had mainly high levels of disease activity. You can also plot these countries by disease activity against the gross domestic product in the countries, seeing that some countries on the left side come worse out, as is Kosovo, Serbia, Lithuania, Poland, Latvia, and Hungary, whereas more affluent countries with higher GDP come better out with a lower disease activity, such as Germany, USA, Netherlands, and Finland. If these patients are being followed up, and if we make groups of rich countries and poor countries, and if we look at what kind of medication these patients for example, biologics, it's clear that at baseline of the assessment, the rich countries had a high percentage of patients on biologics, 33%, against only 11% in the poor countries. And following up these groups for 5 years, there were 13% in each group, which in the meantime, over 4 or 5 years, have had access to biologics, showing that the gap between the rich and the poor countries is not increasing, but it's rather not narrowing or disappearing. And the majority of patients are still not on biologics. So this shows that there's different access to treatment. Musculoskeletal conditions are the single biggest cause of physical disability and a major cause of disability-adjusted life years lost. Major healthcare costs are being given, and of course major productivity loss, and last not least, as a result, major impact on quality of life. I don't need to tell you in this audience these things. The present situation thus is that musculoskeletal diseases in the EU are important. They create a lot of impact on the individual, on the healthcare system, on societies. But we also know that they largely can be prevented and they can be treated. They can be diagnosed. However, the point is that there are disparities and inequities in the treatment of rheumatic diseases in the European countries. And the critical issues for this are lack of awareness, lack of knowledge, and priority. So what can we do about that? One of the possibilities to work with that is the EU MuskNet project. This was developed in 2008 as part of a workshop during an Alliance Against Arthritis event. The project is now supported by the European Commission for Health, by the EULAR, and 22 centers across Europe. And the objective, the intentions of this project, they are to harmonize quality of care and enable equity of care for rheumatic diseases and other musculoskeletal conditions across the whole EU. The general objectives in this project, they are to identify the burden on individuals and societies of these conditions, to set standards of care, both for individuals and healthcare providers, for osteoarthritis and RA. Those are the two disease entities that we are going to concentrate on. Then we want to assess whether these standards are being achieved. We want to overcome the barriers to achieving these standards. And finally, by doing this, improve musculoskeletal health. So how are we going to do that? A network has to be established, a surveillance and information system, including the 22 partners that are part of the project. And this is really embedded within the EULAR, the organization for rheumatic diseases in Europe, for professions, scientists, and patients. And this project will be set and monitored. It will disseminate information, identify and help overcome the barriers that prevent effective treatment and prevention of these conditions. And these aims will be achieved by a number of specific objectives. And that's in a way the main slide in this presentation. We want to create a sustainable and comprehensive surveillance network involving the European stakeholders, key stakeholders. That's the basis. And this is a platform. On this platform, we want to supply updated and harmonized information on health, social employment, and also economic data for these musculoskeletal conditions. And then we want to develop standards of care for osteoarthritis and RA. Further, we want to develop healthcare quality indicators. And we want to evaluate the status on meeting these indicators and standards of care, exemplified by 4 member countries. And we further then want to identify what is it that facilitates and what does inhibit the implementation of these standards of care and healthcare quality indicators. And we want to capitalize and find some good examples that can serve for further implementation in other countries. Finally, we may be able to propose some policy recommendations to be used in everyday life. So in a way, we're creating a platform, we're supplying data on disease, health economy. Then we work on standards of care, indicators, quality indicators of care. Then we're looking whether these quality indicators are being used. What is it that inhibits or facilitates implementation of these standards? And then we can make some recommendations. It's a 3-year project, and the results will be disseminated through web-based health information system, through reports, scientific publications, and of course also through meetings maybe like this. There is a number of centers within Europe involved in this, 22 partners that contribute, and some of them, they're shown in bold, have major responsibility by leading work packages. So this is a major collaborative effort within Europe, and many of you will be involved in that too, I think. So this meets what we need as measures, what the new things are to have the sources with a health monitoring system, showing standards of care, developing them, health care quality indicators, get more knowledge on facilitators and barriers, and finally disseminate the data. The funding is composed by what is being given by the EU, that's almost 1 million euro. The EULAR is contributing with up to 300,000 euro, And a major contribution comes from the individuals, from the partners and collaborators who are donating their time. The budget is there for the researchers and administration, for the project management, communication, dissemination, such as translation to all the European languages, and for meetings. And the structure of the project is done by coordinating at the Royal Cornwall Hospital. And Tony Wolff, who is leading that, he has really been the main person putting together this project by working for a hard time, a long time, being persistent against the EU, finally getting it onto the feet. The associated partners and coordinating partners, of course, are also participating, and the work package leaders are having a major input. So the collaborating partners are listed up here. That again are the work packages. Work package 4, which is the musculoskeletal health status in Europe, led by Tony Wolff. Standards of care by Joseph Smolin from Vienna. Musculoskeletal conditions with healthcare quality indicators by Ingemar Pettersson from Lund, here this city. The barriers and facilitators will be led from the Oslo Center, where also Tore Queen is involved. And the surveillance and information network is also being driven by Tony Wolff. There are also some horizontal packages through the whole project period, with the coordination of the project, the dissemination of the results from the Netherlands, and evaluation of the project from mentor training in Greece. So lots of people involved. Again, visualize the timetable. There are the horizontal packages over the 3-year period, 2010 to 12, with coordination, dissemination, evaluation, and the longitudinal work packages build upon each other, the network establishment, the standards of care part, the healthcare quality indicators, and the facilitators and barriers part. So what progress have we made? The project started in February this year. There was a kickoff meeting in Luxembourg earlier this year, where we also met the EU. The project manager and administrator, they have been appointed and deployed. We have had meetings at the Euler twice. The website has been launched. The first 2 work package meetings have been held. So all together, with all the people involved in these major efforts, I think we can say that we are right on track with this project. And we hope it will contribute in one or the other way to improve healthcare within Europe. Thank you very much.